So let's talk about pelvic fractures here. So who gets these? These are high energy trauma mechanisms, MVCs, falls, crushed injuries, whatever. Elderly ground level falls can still have pelvic fractures. They're usually not going to cause active extrav unless they have blood thinner usage. Well, I should take that back because the majority of elderly patients are on blood thinners now, it seems like. But they're dangerous because of massive hemorrhage. The pelvis is a massive area and it can hold pretty much the entire blood volume, like all 5 liters. So venous bleeding is going to be vastly more common than arterial bleeding. It's like 90% versus 10%. And the retroperitoneal space is another hiding spot that can happen that's associated with pelvic fractures, and it's easily missed. And on exam, what you're going to do is not rock the pelvis. This is one of the biggest pet peeves I have in the trauma bay, is when someone comes in and they just do this weird disco motion to the pelvis and it just doesn't open anything and causes more bleeding. What you're going to do is gently put light AP compression, and it shouldn't give way, basically. You have to do enough of these normal ones in the trauma bay to understand, okay, this is not a normal, stable pelvis. And in that case, in a hypotensive patient, you're going to put a sheet over the pelvis and clip it tight. If you have trauma trousers, whatever you have at your facility, you're putting some type of device to compress and put over the pubic symphysis and close an open book pelvic fracture. Now, the FAST exam here, importantly, the FAST exam is usually negative in these cases. It doesn't rule out a retroperitoneal bleed. And a pelvic x-ray is done in the resus bay in patients who are hypotensive with, concern for unstable pelvis. And that typically does show in what we call an open book pelvis. There's going to be an open pubic symphysis or pubic diastasis, which is that distance increase between the pubic symphysis. It's going to be kind of an open appearance. Now, the management here, we are to talk about pelvic binding, and it's going to be placed at the greater trochanters, not above the umbilicus. So important. It's going to be completely ineffective if it's done above the umbilicus. And you're going to resuscitate blood products, crystalloids, look for other sources of bleeding, FAST, chest x-ray, and of course CT if you can, once you get the patient stabilized and they have blood products going and their blood pressure is more stable. You're going to CT, and hopefully you're calling IR. If they have no other intra-abdominal injuries and they are not getting an X-slap, you are calling IR for embolization and tamponading bleeding if they're hypotensive still. That's it.